doing a number of these profiles, and I'm really looking forward to seeing some of them. I know that the Bangladeshi profile has already been done and that is starting to do its rounds. But with the Sikh profile, what I've liked about this is something that public health has started doing from the beginning. They've been giving like infographics to help us understand what we are reading. And I found this to be really, really helpful. And the work that Justin and Ricky and the team have been doing has not moved away from this. They've done the actual work, but they've also done the infographics to help us understand what is going on in certain communities. Now, I know that you will have all read this from page to page, but I just wanted to highlight about the objectives because Justin will go into the detail, but I was really, really excited when I saw the things where they want. Some of the objectives of this was about identifying and summarizing both physical, mental health, lifestyle behavior, and the wider determinants of health. And also they looked at how they would identify and summarize gaps in knowledge regarding the community. They also, within this, they collated and they presented the information on the 10 key priorities, which for me made it clear, it made it concise, and we could badge it very easily. And also, they didn't just do it on their own. They engaged with the local communities, which Ricky and the team are brilliant at. So it meant that everything you've seen on there is both evidence-based, and they're able to say that they worked with communities. And also what they did was to promote the use of the summaries for the local authority to wider systems within the community. So we didn't just put it on on the infographics and get the writing out there. What the team did, they started to go out there to share it with the public. So for me, today is really important. And I was delighted that Ricky and the team asked me to chair this event. I don't think I'll be doing a great deal, but I will enjoy listening to what's going on because this is an important piece of work. This is a piece of work that I believe for once we have highlighted groups in their entirety, but we've also worked in co-production with them to ensure that it is evidence-based. Now, this afternoon, as you all know, what we normally say to people is during the presentations and what have you, can you please keep your cameras off and mute yourselves out, and when you want to ask any questions when it comes to that bit of it, we ask if you could then just put your hand up in the chat box, and you are allowed, they are allowed, Ricky, to write in the chat box. Yes, yeah. You haven't frozen it, and you are allowed to write in the chat box. What I'm going to do now, and they're going to have Mentimeters and all sorts going on. So it's going to be really interactive. As the cabinet member for this area, I am absolutely delighted to present Justin, who will be going into this in more detail, but more so, I just wanted to say from the beginning, I am just so proud of the team that have done this, because what they have been able to do in a matter of probably less than 2 months, we've never had this type of granular data in this city, and I think it will help us in the future. So on that note, let me hand over to Dr. Ricky wants it back. I'm going to give it back over to Dr. Justin Varney, and I will then sit back and enjoy, and they'll tell me if they want me to do anything else. Thank you very much, and I'll hand over to Dr. Justin Varney. Thank you.
Thank you, Councillor Hamilton, and apologies, colleagues. I'm suffering a little bit with COVID at the moment, so my cough is a bit uncontrollable. So I'm going to just start off by giving a bit of an overview of the community health profiles, and then Ricky will take through some of the details of this specific profile. And it's important to just set out, this is something that is new in public health in Birmingham. What we're trying to do is bring together more clearly the evidence base around the inequalities affecting different communities, and particularly around communities of identity, to help both policymakers make more informed decisions, but also to help communities access that data more easily, to be able to help themselves, but also to use it when they're trying to make arguments for resources, etc. There are limitations. We are reliant on the data that's there, and I have to say, in the context of the faith profiles, there's a lot of data missing. That although there has been commitments by services to collect data, sadly, when you actually try and look at the data, a lot of it is missing. So I think Councillor Hamilton covered the housekeeping, but if I just remind colleagues to mute yourselves. Use the hand icon if you want to ask a question, or put it in the chat box, and there's time at the end for questions and discussion. If you are finding that the slides glitch for you, then often it helps to turn off any what's called VPN. So if you're using like a NetMotion or anything like that to connect for work on your laptop, turning that off will help as well. So Joe, if we can move on to the next slide. So Public Health produced a series of reports each year. There are some which are statutory that the council has to produce, and the main one of these is the Joint Strategic Needs Assessment. That's regularly refreshed, and it's kind of an overarching snapshot of the health and well-being of citizens in Birmingham and the factors that underpin their health and well-being. It's very much looking at inequalities at a city level, and it does draw together data from both the council, the NHS, and other partners like the police. And we are working within the council to look at how we can develop that into a more interactive dashboard, but it's not an easy feat. And we started work to get a better approach to the JSNA back in 2019, but unfortunately COVID has disrupted that. But the latest version is going up on the website shortly. The other statutory report we produce is the Annual Director of Public Health report. It's an independent report that I, as Director of Public Health, write each year on a specific topic or focus that I feel is important to shine a light on. The council have to publish it. It doesn't say where they have to publish it, but they have statutory duty to publish it. And Councillor Hamilton has very much supported me that those reports go to the Health and Wellbeing Board in Birmingham, so they become public documents, and we also report on what happens to the recommendations from those reports through the Health and Wellbeing Board. So they're the two things we have to do. Over the last couple of years, we've been developing what I would call elective evidence reports. So reports that we're choosing to do because we want to support the city to make better evidence-based decisions about the needs of our communities. And there are kind of three different approaches that we're taking. The first is what are called deep dive needs assessments, and the Health and Wellbeing Board, which is the statutory partnership of the council, the NHS, the voluntary community sector, the police, the business sector and the academic sector coming together, and Councillor Hamilton chairs that board, and that board went through a voting process where they kind of chose what topics they want to focus on, and we're gradually working through those deep dive needs assessments, and they bring together both published data, but also they commission focus groups, so they have more what we call qualitative data, people's voices in them, and they make recommendations for action which are taken forward for consideration through the Health and Wellbeing Board. The second thing we do is what are called community health profiles. I'm really delighted tonight we're going to be publicly launching the first of these, which is on our Sikh community. These are, I suppose, a needs assessment light, in a sense that they are desktop analysis, so they're based on the published evidence and grey literature and anything that we can find from population survey data. We don't commission focus groups, and we don't, although we do some community engagement, it's not the same depth or breadth that we do in a needs assessment. And that's really about the capacity in the team and the time that we have. We can either choose to do a very small number of deep dives each year, or we can do a smaller number of deep dives and more of these community health profiles. And Ricky's team are leading on the community health profiles, and our aim and ambition this year is to get the first 10 to 12 published by the end of the financial year. And they very much provide a snapshot of inequalities. The third level that we have, or the third approach we have, are what are called topic-based commissions. And these are really experimental ways of delving deeper into inequalities with specific communities. And this is with very active community collaboration. They take a long time. So the 2 commissions we have at the moment are taking about 2 years to complete their work, and there's significant resource. So we're still learning how to do these. There are new methodology. We have one which is called the Birmingham Poverty Truth Commission, which builds on a pilot that was done a couple of years ago, and that's looking at housing as an issue of inequality in the city. And then we have a partnership with Lewisham, which is looking at the inequalities affecting our African and Caribbean communities, which is called the Black Ear Review. And the Black Ear Review should publish its findings in the spring of next year. So they're the 3 different approaches we have. If we can move on, Joe. Sorry. So the community health profiles are there to provide a snapshot to help us better understand the health inequalities that affect specific communities within the city. They describe them in relation to community of identity, interest, or experience. So identity and interest might be, for example, religion, it might be someone's ethnicity. A community of experience, for example, would be looking at the health inequalities affecting people who've been through the justice system, or people who are veterans, for example. And they set out that difference and the evidence of those inequalities. And if we're able to find evidence around interventions that help, we will also include those in the profile. We publish the profiles on the council's website as a resource to support greater understanding. And the aim is that we'll refresh them every 5 to 8 years. The reason we don't do them more frequently is a lot of the data comes from the census. And that only gets really updated every 5 to 8 years. And in many of these areas, there's relatively little additional research coming out each year. So that's the time frame we've put on for refreshing the profiles. So if we move on again. So this just gives you an overview of the community health profiles and the deep dive reports we're doing this year. So the first of these is the profile on our Sikh community, which we're launching today. We're in the process of commissioning one focused on our Muslim communities. Around Christmas, we'll be launching the community profile of our lesbian community. And then in the spring, the trans community. As Councillor Hamilton mentioned, the Bangladeshi community profile is due to launch in the next week or 2. And that will be followed shortly after by the profile relating to our hearing impaired community. We're currently out to market tendering for support around the remaining profiles in this year. And you'll see there's a strong emphasis on the Commonwealth countries, and that's because we've been able to leverage some additional resource to commission additional profiles in the run-up to the Commonwealth Games to help us better understand the needs of our Commonwealth communities in Birmingham. I've included in the slide also the deep dive reports. The veterans report is already published, and the end of life issues report is due out shortly, with the other 2 coming towards the end of the financial year. So it just gives you an overview of the breadth of these reports coming through, but I'm delighted that Sikh one is our first one, and I hope you'll find it really helpful. So if we move on, Joe. I think, as Councillor Hamilton's alluded to, we've structured the health profiles around the 10 key priority areas, which form the basis of the new health and wellbeing strategy for Birmingham, creating a bolder, healthier city. And it's to enable both staff within the public sector and our communities to understand the evidence and highlight opportunities to address the inequalities that affect them. And we're really hoping that these will be useful tools for you and for us in terms of improving the health and wellbeing of the Sikh community in Birmingham. So if we move on to the next one. These are the 10 themes that form the basis of the Birmingham Creating a Bolder, Healthier Birmingham strategy. It's currently out for consultation, so if you've got any great antibodies to any of these themes, do please go and take part in the consultation. The themes are based on a lot of the engagement we were doing in the year running into the COVID pandemic, and working with NHS and police partners as well, to ensure that this has resonance across the partnership of the Health and Wellbeing Board, because the Health and Wellbeing Board is not just the councillors, the council and other public sector partners, as well as our academic, business and voluntary and community sector partners as well. And they've all played a really active role in shaping these themes. So hopefully they resonate. If we move on again. So we thought we'd share just a bit of the methodology. As I said, this is very much based on published data. So we use national data sources, the majority of which are in the public domain. We also look for any specific reports that have been done. We use a published peer-reviewed journal database search as well. And we also ask local services what data they hold on the community as well, so we can bring that together. And that allows us to bring all of this evidence and data together to produce the final report, which fits against the 10 themes as set out before. If we move on again, Joe. And we get these, the community health profiles will be disseminated. There are two main outputs. So we have a written report and we have a PowerPoint slide set, and Ricky will give you a bit of an overview of the PowerPoint slide set tonight, and the infographics, and we're going to publish them on, they're actually published now on the council's what are called community pages within the public health section of the council. We're committing to translating the written report and the PowerPoint slide set infographics into at least one primary language associated with the community of interest, where that's appropriate. We can't commit to do it in every language. As you'll understand, translation is expensive, but we felt it was important to do it to at least one primary associated language to help communities who don't speak English as their first language access this in their first language as well, to increase the reach and penetration of the information that's held within the reports. We're also developing a YouTube video, which is similar to the presentation we'll give you tonight. And again, we're trying to do that in both English and in a primary associated language. And we run a series of webinars to help people become aware of these, both internally within the council, but also externally, as we're doing tonight, and with wider partners. If we move on, Joe. So now I'm going to hand over to Ricky to take over running through the first of our profiles. And much like Councillor Hamilton, I would just echo my gratitude to Ricky and the team. This has been a huge effort, and coming out of COVID, they have picked up the baton on this. It's something we discussed before the pandemic started, and many of Ricky's team were redeployed into community engagement and into our emergency response. So this has been their kind of phasing back into normal public health, and it's a delight to be able to share this with you tonight. So over to you, Ricky.
Thank you, Justin, and thank you to Councillor Hamilton for chairing today. OK, so basically we're just going to get into it now in terms of what the profile looks like. What I want to say at this point is to kind of highlight a bit what Justin had said through the methodology around the limitations of finding. So where we found where people identified themselves as Sikh, we have used that. We have then looked at even where people have classified themselves as Punjabi or within South Asians, and we've referenced that into the main larger document. So the larger document itself is 66 pages long. This is a slide set that sort of accommodates it. And then there's no point in doing these kind of things if it's just left on a shelf. We've done it in an infographics point, which I'll show you at the end of the slide. So what we've used is the census data. We do know that the new census data would be coming out shortly, but we've kind of made the commitment for it to be refreshed every 5 to 8 years. And we do take into consideration that a lot of the data will be subject to change. What I want to put out at this point is to say that what we're guilty of is having a go. So this is not driven by political agenda or anything along those lines, or with organisations or anything. This is based on the evidence that what we have and what we've tried to find. And where there are gaps, I think that is the first stepping stone from today, is to say of what are the next steps look like. And we do have a bit of an engagement feature as well towards the end of this presentation. I will say that also, when it's particularly down with faith, Some of the limitations, for example, is where people have identified themselves as Ummatari or not. So those are ordained Sikhs and non-ordained Sikhs. That is just a real glimpse of minutiae of where, you know, some of the data going forward would be preferable, because we can then work out what a little bit more of the trends as well. So just wanted to make that clear. There are limitations, there are gaps, but this is just the starting of the journey. Joe. Okay, so just putting it in, you know, I'm from Handsworth, I'm born in Handsworth, and Sohrab Gurdwara is a staunch iconic figure within there. But to kind of give it kind of the local and international context, the Sikh faith was founded in the 16th century by Guru Nanak Dev Ji, and the practice around the philosophy around equality, having that connection with God, and the philosophy around it, and the initiated Sikhs is trying to build that pathway from an individual straight to God. In terms of philosophy and different beliefs within there, you know, we have to take it in consideration. There are different kind of philosophies that kind of work through. But from a factual bit from the next stage, which is from the UK. It's the largest Sikh population outside of India, followed by Canada second, and the UK third. I'm just getting distracted by the video for a second, so just bear with me 1 minute. So you're right to the next slide. What we've done is we've put this into a regional context. So I think Councillor Hamilton was just talking about it, where in terms of some of her wards of where the majority of Sikhs kind of reside, it is looking towards the east side of the city, towards the north. Has this changed? This will have changed significantly from the next set of kind of census data coming through. So at this point today, the highest proportion of Sikhs are located in the Handsworth and the Soho area, and that can be kind of traced back to when first set of migration was waves in the 1950s, where they were coming into Birmingham, and I think also it is worth knowing at this point that there is a lot of transition migration or travelling or with family around Sandwell and Wolverhampton, Wolverhampton has also a significantly high Sikh population also. Okay. One of the stats that I remember from the previous slide. It's okay, Joe. You don't need to go back. That over half of the Sikhs, 52% of the Sikhs, had arrived in Britain before 1981. I was born in 1982, so I was, you know, a result of that. Still young, anyway. Still young. Some of the main health inequalities that we found out is these are the sort of the headlines, really, the spoiler alert in some ways of what's come through. Interestingly, these have been highlighted over more and more over the last 18 months. You will get a copy of all the slides that will tell you the link to get all of this information. So it will be there, so you can sit back and relax. Three of these are one of the highest things that we, myself and the team, had to concentrate over over COVID, which was all around health related and trying to give citizens the best tools, really, of trying to fight COVID around recommendations of physical activities, co-manage the management of disease around diabetes. Those are the kind of free intervention, so to speak, of that what people could do. So when we looked at looked at the data, and when we looked at some of our findings, it's not a surprise that this could even be, exactly the same for some of the other kind of South Asian communities within the city. One of the areas that we found, and is referenced in the larger document, was that there was a higher percentage of Sikh women with polycystic ovary syndrome compared to the general population, which was sometimes one of the things that we found out. But also there was a lack of evidence, especially around kind of diabetes data. It was going down for the Punjabi community, but nothing faith-based, and that is a similar theme throughout the actual findings. So when we were looking at the health themes, I think it was important that where we're starting off is getting the best start in life. One of the key things, one of the key findings that we found, and again, if it was localized data, we would use it, was around the vaccination. And this is really key for something that we're going to be talking around COVID, around vaccination rates. So just under 8,000 children registered as Sikh in Birmingham. And in terms of utilising their journey into health-based interventions around the vaccination, measles is the measles vaccination that we've given there, is showing that there's good rates of high vaccination within the Sikh community, and that is also represented in the COVID vaccination uptake as well. Joe. Now, this is one of the areas where my kind of background, when I used to be the lead trainer for the Birmingham Drug and Alcohol Action Team, was around sort of drugs and alcohol. And the second stat in particular, we've got a lot of Sikh charities who started to work around mental health, significant, charities who are making real good breadths and leaps in there. But there was a lack of data trying to get that really to sort of coming through. So mental health Sikhs were less likely to be experiencing reporting mental health, ill health, than those who identified as Christian, Muslim, Hindu, and those identified as any other religion. Would that change now because of the relationship of talking therapies and the community? I think that is getting better. The second one, which is the interesting one, which was the Joseph Roundtree Foundation, had done a study, and numbers of people who identify themselves as Sikh who drink is higher than the general population. 1 in 4 have a family member with a drinking problem. That was from the sample group that had been taken. But we have stated from there that's most likely to be from. It didn't differentiate between ordained and non-ordained Sikhs as well. Smoking is a similar thing. In relation to drugs, the NDTMS, the National Treatment Monitoring System, Drug and Alcohol Treatment Monitoring System, there wasn't actual data that can be broken down into kind of faith or Punjabi. The general consensus around that, the general kind of statement is that just under 280,000 people are in treatment nationally for drug and alcohol use, and less than 3% come from a South Asian background. So anecdotally, I know within the community around alcohol, higher numbers. Is that getting reflected into the treatment system? Not at this point. So healthy and affordable food. This was a really interesting stat that we managed to kind of break down from a study from Minihine, published in the International Journal of Obesity, that the average calorie intake of Sikhs is 3,216 calories, and they have a higher daily calorie intake from the daily recommended of 2,000 calories. How this is kind of being reflective in the environment of the Gurdwara. So one of the key functions within a Gurdwara is to provide free food in the form of langar. So there was a piece of work that had been started, had it been finished, of looking at calories that the average serving was given within the Gurdwara. Key kind of intervention really in trying to building up healthier lifestyles and looking in terms of healthy and affordable food. The food agenda is something that the Birmingham Public Health is committed to also. So this was a really good, important kind of headline that had come out of it. Around obesity, there was limited information exclusively for the Sikhs. However, Sikh males have significantly higher body fat compared to Caucasian male. Has that links into the diabetes? That kind of journey is kind of well traced, really. So there are other pieces of work, and where I'm giving you kind of brief headlines now, and the actual document itself, it goes through in a little bit deeper for you to see. Active every age. Yeah, so this was another one around physical activity. So this information was coming from came from ONS data as well, and from Public Health England. So less Sikhs compete in government recommendations of 150 minutes, again, this was one of the key things that we were pushing forward during our COVID work, where we commissioned some of our communities to work with their clients or their community groups that they had. And one thing that came through the British Sikh report, over 2,000 Sikh participants took place. 46% stated that they set aside time for exercise. How this can be moved forward in this document itself, there isn't any recommendations with it. This is a community intelligence exercise to say these are the findings, and almost empowering the community to say what are we going to tackle next. Last point there was those who were age 65 plus were most likely to set aside for time for physical activity. Now, whether there's a relationship with grandparents having time to go out or going the journey to the temple, whether that has an impact on it, I think it plays a bit of a key part. Next part is around kind of working and learning well, and this was very interesting as well from qualifications point of view. This was taken from the Office of National Statistics. 22% of Sikhs have no qualifications. This is lower than the Birmingham average of 28%. And then 28% have a level 4 qualification. So that's the equivalent of your first 2 years at university. And so that's higher than the Birmingham average again, which is 23%. The employment-wise, 65.7% of Sikhs are economically active. This is higher than the Birmingham average as well, 59.2%. The household living one, as you can probably see, is 25% Sikh population in Birmingham live with more than one person in the house, compared to 11% of the total population. That's an interesting one, which is most likely kind of to change really in terms of culturally. There might have been an impact of where the younger generation are moving out of households. So would that be reflected in the 2021 census data, where it's likely to have a significant change on that part? And the last bit, managers, Sikhs are most likely to be managers than general population within Birmingham, and that's referenced again within the British Sikh report that had been published. Protect to detect. Now this goes back to the one of the first slides, which we were talking about vaccination. I think what was really key was at the time when COVID was actually hitting through, that when the ethnicity data that we were looking for, it just didn't exist. And so we kind of dug in, and in a couple of slides more, there we talk about COVID a little bit in greater depth. But from this point, protect and detect, prevention better than the cure. Cancer screening, on average, the colorectal cancer screening uptake among Sikhs is 32%, which is lower than the general population in England and Scotland, which is 61%. So there is a lot of work to be kind of looking at those things there. Vaccination rates, which I'll get through. Sorry, my computer just crashed for a second. Perfect timing. To go. Yeah, so Sikhs are fourth behind Christian and Jewish and the Hindu community, but higher than the Muslim population. So that's just around from the coronavirus information that we got from May earlier on this year. Has that changed as people having second jabs, etc., and maybe perhaps the booster? I think that will likely to change again once more. The sexual health infections one was really interesting in that study, which was from Cohen MM in 2014. And one of the things was the perception that girls get STIs more, and also if you don't have them, you don't have symptoms. So those sexual health infections, if you can't see, then they don't exist. And one of the interesting parts of it was the belief that Sikh males don't get that. Whether that was how that's related or the reasons for it is still it didn't really go into greater depth. We were limited in some of the with that information. Aging and dying well is the next section, and this is where we were finding some of the end of life and the dying dying area was quite. There was a there was a conversation what Dr. Justin Varney said to us at the beginning of this year, which was around the conversation of end of life. and the conversation around speaking about death. And death is such a really poignant, significant part of the Sikh faith, as the beliefs are that the journey doesn't end there. The soul continues on to the next part. So like kind of reading some of this data it was bringing, it's hard to kind of park the emotion and a bit of the data in at one point. So from a diabetes point, the risk of South Asians developing diabetes is between 2 or 6 times higher than compared to white Europeans. I think someone's just made a comment within the chat there, which could be a factor. The other part around dementia, and my family's experienced this as well, and anecdotally I'm hearing more and more. 11% of Sikh households reported having somebody living with dementia or Alzheimer's, and stigma, unfortunately, and negative perceptions of dementia diagnosis contribute to families concealing symptoms and diagnosis from their community. This is an area which we've had the data is coming more and more in, and a lot of other studies are undertaken, but it haven't been completed at this time. So some of the areas of what we're closing the gaps, so again, based on some of our Public Health England research analysis, and from the Office of National Statistics and Census data, we've managed to put together. So the next 2 slides are quite interesting, really. So living in the highest 20% of deprived areas in Birmingham. By faith, Sikhs are 4th, so 46%. This is less than Muslim, who 84%, and Buddhist 51%, Christian 50%, but more than Hindu, 45%, Jewish citizens. So 2.9% of Sikhs live in the least deprived areas of the city. Then when we're linking this with our life expectancy and deprivation data, 45.7% of Sikhs live in the most deprived areas. So in essence, so one side of Birmingham to the other one, Birmingham can expect to live 20 fewer years. The next slide actually kind of puts this more into kind of context. So this is one where we looked at kind of green and sustainable future. So green wildlife, or however you want to say it, is a very important philosophy within the Sikh faith. Gurus had emphasized about the connection with nature and being one with God and with earth. Looking at this way, if you look at the green spaces that are available within the city, and where I said where the Sikh population more towards the north and east side of the west side of the city, when we've got these justice wards that we were able to combine in. So when you combine the data to come in, 36% of Birmingham Sikh population live in the second least preferable wards. So 9.1% of Sikhs live in the most preferable areas, and that is where those areas which have been highlighted has a lot more green spaces than other parts of the city. And the last bit that I'm going to go on in terms of the themes that have been highlighted is around. Just man, 1 second. Sorry, Justin just writing something there. One of the areas that had come through, which was around mitigating the legacy of COVID-19. That religion was really poorly recorded, especially at the first part of the COVID pandemic. This was really crucial in terms of working with communities to highlight some areas. So there was some limited amount of work that had happened at that time. There was 96% of Sikhs were worried about the high numbers of deaths within the Sikh community. So there was some reporting that had come out at that time. I think those things, there's one who will increase. 40% of the total deaths of Sikhs in the UK in the West Midlands from January to 2020. This increased by 60% by mid-April 2020. Some of those reasons we've addressed in the bigger document as well. So you can have a look at that. I ain't putting on the link yet, otherwise you're not going to just jump towards the end of it and then it will wreck the flow of this. But in essence, there's a lot of information that I've really just gone through there and kind of moved at pace in terms of information. What we did then was took it to the next stage, really, which is Joe. Just we've put it into infographic formality. So this is also where we've summarized the themes of the sets. So we made 4 sets of these infographics that have been done. The next one is breaking it down into some of the themes of the some of the reasons what we've got and some of the key statistics that we've found through. The next one again, Joe. We've again looking at that dying well one, and some things are a bit difficult to try and explain. The role of karma within the Sikh community is a big thing. It goes away more than traditional meanings of within the Western world of what karma, the karma belief is. But we've tried to address it as the best as we can within here. And then what we've also then done is to take it another step, which is where we've translated these into Punjabi. So you can blast through the next 2 or 3 so you can see it from that bit. What we have also done is translated the actual whole document, the 66 page document in Punjabi as well. So this was what we had done in terms of the next steps with this. We had written the reports out. We're doing a little briefing of this in a YouTube video, in a bite-sized kind of YouTube video, which you can share. What we have also done then now is we trial this internally within the BCC. So some of our colleagues have joined us today to get some of the information and some feedback. I think it's really important to kind of highlight that this is one of the first ones that we've also done. So where there's feedback, we will take it forward and to do that. But it was really crucial in terms of saying this hasn't been done before, and what the questions are to kind of the other areas, like Sandwell, for example, or Wolverhampton, is if this exercise was being repeated there in terms of our findings, what would that would look like? What we would be asking to do for you guys to do is to share the document as much as you can, all the resources, and if there was any kind of bespoke work that there's an area that we could kind of consider depending on what it is, if there's other kind of pieces of work that we're doing of how to bring that towards together. So in terms of what the engagement, there's a couple of things now where we will open up for questions and then also go into some of our Mentimeters activities. So I'm limited in terms of what I can see on the chat. So I know there's a couple of hands up.
Don't worry, Ricky. I'll help you out there as long as you don't mind me doing so.
No,
okay.
No, that's fine.
Right, there is a question from Sukhdev Singh. Sukhdev, would you like to come in and say your question, please?
Thank you. First of all, can I congratulate Ricky and Justin's team on providing the first formal report, which is of great interest to me. I'm a GP by trade, and I dedicated the last 35 years of my life to primary care work. And for those that aren't GPs, just to say that the majority of the population is registered with a GP, more than the resident, in other words, by voting. And 90% of the population we've seen in 3 years. So I have actually, in my 35 years, seen repeatedly nearly all the Sikh population that resided within the area that I work, which is, I think Sikhs are probably the 3rd largest. But some of the things that I've picked up over the last 3 decades are very, very similar, surprisingly similar to what Ricky has shown us. From mental health, and my main interest has been transcultural psychiatry since the 90s, and depression in particular. But yes, definitely, South Asians and Sikhs have a very low uptake of counselling, which is a very specific area that we need to improve. I worked on an alcohol unit for about 10 years, and I remember Ash Khan, Dr. Khan, who was a psychiatrist, said, the 2 commonest groups on our alcohol inpatient unit are the Irish and the Punjabi Sikhs. And again, that remains a really, really big issue. And with the big heart disease and diabetes prevalence, I can just share some sort of specific data. The average prevalence of diabetes is about 5.7% in the UK generalized. But for South Asia, just between 7 and 21%, which is a huge increase compared to the general population. And Sikhs obviously bob up and down depending on how obese they are or if there's a family history. So I agree totally with all the findings. Again, another aspect of exercise which I'd just like to add to Ricky's is if you look at gym membership, one of the lowest gym membership rates are for the Sikh community. And the last one about obesity, yes, as South Asians, as Sikhs, we have what's called a lot of central obesity, which is in the abdomen, which is the most dangerous to health, as opposed to fat around the rest of the body, which is less dangerous. So from a health perspective, there are huge amounts that our NHS needs to adopt to ensure better culturally competent practice, which basically means when doctors or health professionals, be they nurses or counsellors, see a Sikh or another ethnic group, they need to know the nuances of how the disease is different in that community, not just based on the culture, but also the real differences. And we'll be able to therefore get better outcomes. So, Ricky, I hope...
I'm
really,
ever so sorry, can I stop you there? Because there's a few other people wanting to speak, but your points have been well made.
Yeah, all I'm saying is that I'm hoping this adds to improved outcomes in the health of our communities. Thank you.
Brilliant, thank you. Can I go straight over to Jazz, then over to Sanjez from the Sikh Women's, please? Jazz?
Hi, yes, thank you. I know Justin's just put a comment back to my question, but I'll ask it anyway if you don't mind. It was just around the quote that said that Sikh community is less likely to report or experience mental illness symptoms, and I was curious as to kind of why that may be. Is it the traditional reasons that we've been told before in terms of shame, stigma, people not wanting to report it, cultural, religious reasons, all that kind of stuff? Or is there new emerging evidence that suggests there may be other precipitating factors for that?
Right, are you writing these down, Ricky? And
yes,
I know
I think.
Let me just ask the last person to ask their question, and then Ricky, if you and Justin can go through any of the points you want to raise. I've got a question from Gersharan Kaur. Hello. Gersharan Kaur.
Hi, sorry, apologies. I thought I was after a few other colleagues. I really want to congratulate the team for undertaking this piece of work. I have worked as South Asian Health Service Manager in the PCT days in the neighboring areas of Birmingham. And since then, I'm a commissioner in the local area. So I just wanted to highlight that the issues flagged, I think something similar to what Sukhdev mentioned as well. The issues that the report highlights aren't very new. Most of us probably would have guessed, with closed eyes, what this report may have highlighted. So it's reassuring, though, to, see the work that has gone into the compilation of the report, obviously. My question is, now the issues aren't new. We've all been aware of majority of these, if not all of them, for some time now. What initiatives or what actions will be taken in terms of addressing the health inequalities, different to what has already been trialed and implemented in the local, area, Birmingham and Black Country for quite a while now? We know health inequalities have been, kind of cemented as a result of the pandemic because of certain communities being affected, disproportionately. But the inequalities have always been there. And one of the issues in terms of health inequalities is also access to services, not just in terms of, the service provision, but actually just accessing the services at point of delivery or contact. So what thought process may have gone into how the issues that will be picked up in these, specific community profiles will be addressed in Birmingham. Thank you.
Thank you for that. Before we get the last two questions in, Justin or Ricky, do you want to respond to any of those points?
Sure, I'll jump in quickly on those. So as I put in the chat on the mental health point, so what the research, and thinking back to the original papers, most of them were looking at the context of mental health and faith. So it was not specific to the Sikh community, and what they were really looking at was whether people with faith have better mental health than people without a faith or belief. And in general, almost all of the research says yes, if you've got a faith and a religion and you are actively practicing it, whether you go to temple or not doesn't matter, but if you are actively practicing it, you're praying, etc., that is a protective factor in terms of common mental health issues like depression and anxiety. The issue around stigma is present in all faiths and beliefs as well. So the research pretty much kind of says two things. On one side, religion and faith is protective, but on the other side, there may be more stigma in some religious communities. And what was interesting is the Sikh community does come out better than some of the other religious communities in that research. So there is something about the Sikh faith which puts it slightly higher than some of the other religions, shall we say, in terms of protecting people's mental health, which I think is good news. In terms of the second point about kind of the so what, I mean, one of the reasons to do these community health profiles in the way we're doing them is because actually, I've worked in the NHS before I came to council. And I'm not surprised what you're saying in terms of many of you in the community will go, yep, know this, but it's not written down and it's not brought together in this way. And by bringing together the data in this way, it is about prompting the discussion about so what? So what's going to happen differently, particularly in the context of things like NHS services. So the profiles, because they go to the Health and Wellbeing Board, specifically go to our NHS partners, for them to highlight and to look at and to understand. And there are some things, as Ricky alluded to, where there is really clear inequality affecting the Sikh community, which then allows you to use that as a leverage to go, OK, let's look at, for example, treatment services for women affected by polycystic ovaries. How are they inclusive of women of the Sikh faith? Have we thought about this? And using that as a door to start the conversation, because bluntly, we've had decades of public services going, we're going to be better at equalities, and it hasn't moved forward. So by trying to get it be very specific and give ways to hook in into specific services and particular areas of discussion, then I hope we can move that conversation forward. But the other reason we've done this is to put this in the public domain and to give it to you as communities to use to lobby, to use to influence, to use to raise the conversation. We're doing it. We could have done this kind of thing, kept it in-house within council and just used it for our own staff. But it was really important to Councillor Hamilton and to myself that this is something that was a public document to give you the knowledge and the evidence base to back that up, to back up your personal experiences with here's what the data shows, to help move the system forward and to make sure that these inequalities don't get hidden and can be discussed in a way which tacks back to evidence as well as people's lived experience.
That's so true, Justin. And before I bring Ricky in, being a councillor in Answorth Wood, many of these issues, as has been said, we knew they were there, but they were not written anywhere where we could just put our hand on it. And the difference with this is it's there, and there are certain aspects that I think the community wants answers. And I think this will help us to seek the answers that the community wants, because sometimes Justin is so right. The stigma, people don't want others to know in the community, but they need to be addressed. And this is a way of addressing some of the issues without looking at individuals, but as a community type thing. So I really, really welcome that this work has been done by Ricky and his team, and done so quickly. So it shows that it can be done if people put their hearts and minds to it. So what I'm going to do, Ricky, did you want to add anything to what Justin has just said?
Not really at that point. What I'm keen to try and get everybody in there is to get onto the Mentimeter, because there's an opportunity.
No, Rick, you're not going to do that, because we've got 2 people left.
Sorry, I can't see it from my
I know
screen.
you want to get onto that Mentimeter,
No,
but
cool.
we've talked about co-production,
sure.
Let's hear what others are saying. So you will get to that Mentimeter, my friend, you will.
Cool. All right, yes.
Sandesh from the Sikh Women's, and then straight over to a very honourable young man, Mr. Amrik Singh Opai, is it Amrik? But over to Amrik, a man I respect very much. Sandesh?
Hi everyone. Paula, it's Shadish, and I'm
from... Oh, thank you, Shadish. Sorry about that, but you corrected me, so I'll let you carry on.
Yes, Shadish from Sikh Women's Aid. So well, I think that is really interesting, the data, and I won't go into that, but it's really informative. So thank you for that, because it actually highlights some real concerns. What I would say is, coming from the Punjabi Sikh community, that I think a lot of that is a tip of the iceberg, because we know what goes on in our community, and we're very good at hiding what is actually happening. But it's a really great starting point, which is really important. I was just surprised that sort of domestic abuse didn't feature on there anywhere, because for me, my work over the last 26 years has involved domestic abuse, and I know how serious domestic abuse is in our community, and I understand potentially might be because maybe there's not enough data on it, or there's no research around specifically the Sikh and Punjabi community. And I just wanted to let you all know that Sikh Women's Aid this year has done a survey, and we're writing a report around domestic and sexual violence within the Sikh and Punjabi community. And it's been an open survey, so anonymized. And we hope that, we know what the data says because we're writing a report on it, but we hope that that information might be able to feed in further later on into public health, and when you do this piece of work again around this community, because it's the numbers within our community, from what we're seeing from the survey, are much higher. The situation is much more serious in some of the other communities, like the sort of white generic community, when it comes to domestic and sexual violence in adults, but also abuse for children, people who are adults now, who have experienced child abuse, and the trauma and the impact that that has had on them going forward as adults. So things like anger problems, relationship problems, alcohol problems. And then obviously, because we've got this issue with alcohol, along comes domestic abuse with that for many of the victims I've worked with. And just going back to the British Sikh report, I can't remember which year it is, but on one of them it talks about the mental health of people, where they say only about 10%, I think people said 1 in 10 said that they'd experienced mental health. But the other question next to that is, how many people do you know who have experienced mental health? And that number is much higher. So that tells me people are not willing to admit that they've got it, but they'll tell you that other people have got it. And that number is something like 70-75%. So it's something that does need to be looked at. And I know it's time consuming and resources.
Sadish, I hate to cut you off in full flow, but I think you've sort of made the point, and it's a really valid point, because what I will do, I will add to that for Ricky. Ricky, can this document be added to, or will we not revisit it for the next 4 or 5 years? Because to be honest, Sadish makes a really valuable point, and it's something I saw a lot of in certain areas that I've worked in, even as a district nurse.
Sure. There's a couple of things. One is like just the second part is where we would be feeding into what Stephanie's put in the domestic abuse needs assessment from our findings to do that. I think that is a kind of a very easy access for us to try and address those issues to come up with. And then when we do the refresh, obviously it would be in there. In this document, just to kind of put at ease, Sadesh, which was Dr. Sarah Galvani did a piece of work around alcohol within the community, which Aquarius had gone out, who we commissioned around to do the Shanti project. But in there, it was highlighting around the relationship with alcohol, with domestic violence, and the other bit which was coming strong through around sexual abuse, which is one of the big taboo subjects at that time. I think one of the learning experience from that was really how does those conversations actually get into the community, rather than just kind of stopping at the first point. And we did look at that in terms of how we were going to put our infographics out and from there. But the easiest thing that we can do is, like I said to you, is to want to reassure you that our findings will go into the needs assessment. We'll have the conversations at that point. And the second part is when we do address it, we'll do it.
Thanks, Ricky. I want to go over to Amrit, but Justin's made a really valuable point in the comments. So Justin, can you chip in and just respond, just add a little bit more to what's being said? Because I thought that was a valuable point.
Yeah, so I think there are two things, and do feed into the domestic abuse needs assessment that's going on at the moment. I think one of the things that's really important, and one of the things I really hope that comes out of these community profiles, is that it triggers communities to feed into these kind of needs assessments, because it shouldn't be that the discussion of domestic abuse within the Sikh community only happens in the Sikh community profile. It needs to be a part of the domestic abuse needs assessment, and that needs to look at religion and faith. So really important point. I think there have been a couple of questions in the chat about other things like organ donation and health screening by age, and we are ultimately limited by what data is available and whether we can get access to it, and in some areas whether we can get it down to a granular level or not. And again, one of the things that's come out is that overlap. And although many of the Punjabi community are from the Sikh community, the two are not complete overlaps, and therefore we've got to be really careful about saying this is a profile looking at our Sikh community. And although many of our Sikh community do identify from the Punjabi community, that doesn't include everyone. So there are some limitations to what we can do, and that's just the reality of the data that we have. But I mean, this is about prompting a conversation and helping communities to argue their position and demonstrate the position based on the data that's available.
Dr. Varney, I'm going to be a chair, and I'm going to ask you if you can hold back, and so I can bring Amrit in, so we can get that last point in. I hope you don't mind, but I desperately want to hear from Amrit. Amrit, over to you.
Paula, thank you. Bless you for your kind words. And as everybody said, thank you, Justin and Ricky, for bringing this piece of work together. Very long overdue, but very important. And I think, as we've already heard tonight, and I endorse and applaud all the speakers who have said their piece on behalf of the community, because I think it is important. But one thing that has been proven tonight is that the conversation has started. And that's important, because this data now is prompting us to have those conversations. And regarding organ donation, plasma donation, domestic violence, we as a community need to go away and now apply those pressure points to the right people, right places, and say, how do we get this on the agenda, and how do we have these conversations? Also, there's an onus on us as a community to create those safe spaces to allow those conversations to take place. I would like to conclude by saying some of you on the call are going to be part of, or will be part of, the Addressing Health Inequalities across the region. That will be an opportunity to take data like this at a granular level and feed it into the regional work that is going on addressing health inequalities. And Councillor Paulette, and I know Justin, you guys will be involved. I would encourage you to try and get this data replicated and produced across the other regions, especially the Black Country and beyond, to make sure that when we do start tackling those inequalities, we can do. And I encourage those who are pulling this data together to work with the communities and start coming up with some recommendations, because what we can then do through that inequality piece of work that Andy Street is leading on, we can then amplify some of those messages, address some of those messages, and highlight what needs to be done, and hopefully start closing that gap and work together on closing the gap. Paulette, thank you very much.
Okay then, Amrit, thank you, and it's good to hear from you. So Ricky, can I hand back to you? Thanks. If you want to make any points on the last two comments, you're welcome to. Otherwise, you can go over to your mentor meeting.
Yeah, I'm going to go over to the mentor, because I think everything's been concluded pretty well in our responses.
Thank you.
So what we're going to be doing now is we're going to actually go through a bit of Mentimeter, which is we're going to ask some kind of monitoring and demographic information, and this is in part of the engagement. So if you can bring it has everybody managed to get the QR code? There's the link is in within our chat. It might be easier to do on your mobile phone than anything else. And what we're able to do then is just kind of record some of this information. So this is a disclaimer basically of saying of how we're going to be utilizing it. So are you able to go on to the next bit, Joe? So this is just us getting some stuff. So like, there's 40 people on this call, and there's only saying, I know that there's bottom 7, that there's 7 people have answered. So I'm going to be watching this very careful, especially Cool One Opal, because he's had his camera on. So I know he's very well interested into this. So if you can, it doesn't matter if you can't do it now, you can just kind of do this in at your own pace. But the real gold is in the next couple of slides that we've got. So what I would request is for you to fill this in as much as you can. Joe, can you go on to the next one for me, please? Yeah, on to the next after this one. Next one, please. Next one, please. Next one. Next part. Right. So once you've gone through the Mentimeter, you should come up to this question really, and this is how we are looking to kind of move on in terms of the engagement. So how would you or your organization cascade this information into the Sikh community with key stakeholders? So we've got somebody coming back with social media. What else are we looking for? I mean, we've got bespoke workshops. So we've got the bulletins, blogs, website. Again, kind of be linked into kind of social media. Is there anything key from your experiences of working with the community that is being missed? Site research in my lectures for uni students. Okay. Share on WhatsApp groups. Yeah, we've seen how effective WhatsApp has been, especially over the last 18 months. Share with team managers, look at doing targeted work with Sikh communities based on findings, especially around mental health and well-being. Yeah, okay, that's great. So again, we've got some kind of good answers back. The next one, Joe? Because Sharon comes up with a good around a localized action plan. It could be a ward action plan. What opportunities do you have to embed the findings in your line of work? Now, this is a really it can be a bit of a tricky one. So some of the findings that we've got, or some of the things that you kind of experienced, you might have already got an idea of how to do this. So we've had a conversation with our kind of BCC work, our work staff, when we did the internal event, and we got some really good kind of feedback at that point. So it was discussions with their HR, looking at any kind of work safe space in terms of like increasing breakout, just having the opportunity of a walking group within the teams. Transformation team around health inequalities around BCWP. Right, so build into the VSC alliances in relation to the integrated care systems. It's a good one. Okay, I'm going to move on to the next slide now, Joe. Now this is one where we focused in on one of the slides. So we had highlighted the 6 kind of key most important health inequalities highlighted into there for the Sikh community. This is a chance for you to kind of rank what would you see is the most highest priority, and work our way down it. So if you guys can work through Menti and get up to this point, this would be really, really helpful, because this is talking what Amrik had said around what we're looking at the most important parts to kind of apply those pressures within the community, can kind of lobby as well. So the first one we've got is, and that's the good thing about Menti, as people are answering, you can just see things start dancing around a little bit more. So one of the first, what's coming out pretty strong to start off with is having those cultural language barriers between Sikhs and health service provisions. And the second one is high rates of diabetes. conversation yet is still there. And what we will be doing is that once we've got this feedback and engagement, we'll be sharing this as well. Also we'll be emailing it you out in terms of the findings and the comments that have been made. Okay, so that one's coming out pretty strong in terms of around building those health, navigating around the health system around and the conversation between the Sikh community and health service provisions. Joe? And again, in terms of from a learning point of view, what should future engagement of the Sikh profile look like? So for ourselves, we've done an internal event, we've just done this external one, but what, building on the steps of moving forward on the journey, what should it look like? Hopefully there's a lag on there and someone writes something really quickly. Collaboration now, here we go. Inclusive, meaningful, collaborative, tangible actions, yep. Sharing of success. So sharing good practice. And that's one of the things that we want to do, is trying to get activate the community to go to the neighbouring areas such as Sandwell and Wolverhampton to say, can they repeat this exercise over there? It'll be as more data comes in, we'll have a more comprehensive kind of wider action. Okay, Joe, next one. And this is a really good one in terms of like measuring the success of this. How will we know what we've made a difference? What would that look like? There's been some comments in the chat as well which kind of relate to this. Actions aligned to identify health inequalities, yet health outcomes improve. Anything else? I'll wait for one more comment and then move on. Improve awareness, health matters, improve health outcomes, Sikh communities, awareness and current. Okay, Joe.
I think that's the last one.
Yeah, okay, thanks, Joe. Joe, can you just do us a favor and just show, put the link onto the website and where they can find this information with access to the greater. Yeah, thank you.
Yeah,
we'll get to
I'll do that now.
So we've already launched this onto our website. And what you can have a look is you can download a copy. Joe, are you able to just share your screen? So just show us on the website.
Yeah, of course.
Thank you. So if you in the section in Birmingham City Council, there's a section called Health and Wellbeing, and we have got the overview within there. So it gives you a bit of brief of what this was about. Joe, can you scroll down? Carry on to the actual link, please, to the document. And right at the bottom there, you've got it in English and Punjabi. So we've got the profile and we've got the set of infographics within there. Once it's downloaded, you'll know you're on the right one. And we've got the community profile. So this looks at the slide set of what we've put in, what we've just discussed in detail, referenced. And again, take what you want from it, which is the most key thing, really. As we said, this is one of the first of many. This is a learning experience for the team and for public health as well. So this is the thing. Is there any other sort of final comments before I hand over to Councillor Hamilton to close? I'm going to take that as a no, Councillor Hamilton. Are you? I'm going to hand it back over to yourself.
Okay, right. I think you've stunned them to silence, Ricky. So what I'm going to do is, if there are no further questions, do you want to do any finishing remarks, Justin? I know you're not 100% well, but I do think, do you want to say any finishing remarks?
Yeah, I mean, just final one to say, huge thank you to the team. I know I've kept your feet to the fire on this one. And I'm really pleased at the positive reaction we've had from colleagues tonight. This is the start of, I hope, a series of these community profiles which will really help our communities across Birmingham be more empowered to raise their voices and to use the evidence and the data that we have to support their own communities, and also to influence the system and hold us to account. So I am really pleased that we've been able to launch this one tonight. I hope you will also help us disseminate the others as they start to be published over the next couple of months, and do feedback to the team of the ways we can improve it as we go forward, because this is a new way of approaching these issues, and we are on a learning curve, but I'm really pleased at the reaction and what you've shared with us tonight. So it's a really good opportunity for us to make a difference for our Sikh community in Birmingham. So back to you, Councillor Hamilton.
You're on mute, Councillor Hamilton.
Oh, I'm having one of those evenings. Just as a final finishing remarks, can I also say, as the Cabinet member leading all of this, it has been a pleasure working with Public Health. The way they have managed to change, adapt, working under pressure, and do some of the best work I've seen in public health in the last 2.5 years. I'm publicly saying thank you to them. This profile was needed. It was absolutely needed. And Ricky and his team, under the leadership of Justin, has delivered on it. So for me as a Cabinet member and as somebody that works within the communities, needing the information, this is a start point. And I agree with the lady from the Sikh Women Group, Sandesh, I think I keep getting the name wrong, but what she said is true. It's a start point, and we have to keep adding to certain bits of it and ensuring that that information, as Amrik has said, is scaled upwards so we can get some real change. But just to add, we're not going to wait, Amrik, for you guys to do what you're doing on a regional level. Where we can make changes on a local level, the plan is that we do that, because we're not just about producing reports. These reports are underpinning other work that's being done in equalities, looking at equalities and diversity. And the plan is, as we do this work, if we can see where changes and policies can be changed and things can be done, and we can influence the health service through the Health and Wellbeing Board and through other places in the system, we will do it. So on that note, I'm just going to do a big shout out for Ricky and his team, and I just want to do a big shout out for all of you that have come here and given of your time tonight, and I just want to thank you and enjoy your onward meetings, and just thank you for coming. It's been a really, really good meeting. Thank you very much, and good night.
Thank you.
Thank you, Paulette.
My pleasure.
Thank you. Thank you. Bye.
Bye.
Thank you. Great work.
Thank you.